Hi, welcome everyone. Thank you for joining us for today's call. My name is Judy Willard and I am the Circle Membership Director for the Policy Circle, which means that I'm the first point of contact for all of our amazing Circle leaders. And shout out to all of you gals who are on the call with us today. You guys are the wings beneath our wings and we love our Circle leaders. And if you're out there and you're not a Circle leader and you want to learn how, contact me. We want to bring the mission to more people because those are the ladies doing the hard work in the communities. So I'm just going to go over a couple of housekeeping rules and then turn it over to Sylvie. We are recording this conversation. You are all currently muted. If you would like to participate during the Q&A time, you will need to raise your hand. And how you do that is you click on the participants button at the bottom of your viewing screen, and then a sidebar will show up with all the names of the participants. And then at the bottom of that, you will see raised hands. Now, since we're diving into technology, there's a shortcut. If you're using a Mac, you can use Option Y to raise your hand. And if you're using Windows, you can do Alt Y to raise your hand. And if you've dialed in by phone, you can hit *9. And then I will call you. I will see a little blue hand by your name, and then I will call you by name and unmute you so that you can ask your question. If you have a question but you don't want to ask it verbally, you can send it to me in the chat box, and then I can read it for you during the Q&A session. So again, thank you for joining us, and I'm going to put my name in the chat box and email address so anybody can contact me about more information about getting the Policy Circle out in the world. So I'd like to turn it over to Sylvie, our CEO and co-founder of the Policy Circle, Sylvie Legere.
Very well, thank you. Thank you, Judy, for the introduction and setting up this webinar. Thank you, everyone, for joining. We have about 80, I think we have 100 registration. I think we're expecting about 80 people participating. So thank you so much. And welcome to this Policy Circle, Move the Needle Zoominar, as we call it. This is an opportunity for us to really bring together Policy Circle leaders, members, supporters, and friends. We now have grown into a national organization with 322 circles in 40 states. And our goal with these webinars is, in this crisis, everyone realizes the extent to which government decision impacts our daily life. And our goal is really, our mission is to inform, inspire, and develop civic leaders to lead and engage in their communities. So that means really equipping us with the knowledge and the information to go beyond the headlines and in order to constructively interact with policymakers in our communities. So with that, I'm really excited today to be joined by a very special guest. And today, Angela Brawley, one of the co-founders, my co-founder to the Policy Circle, will be interviewing Sally Pipes and Gloria Sachdev. Just to give a little background on Angela is a recognized leader in business and healthcare. Angela now serves on the board of directors of Brookfield Asset Management, ExxonMobil, Lowe's, Procter & Gamble, and Angela was formerly the chair, president, and CEO of WellPoint, now called Anthem. So Angela, I will turn it over to you to introduce Gloria and Sally.
Thank you, Thank you, Sylvie. I am so pleased to be able to have this needle call on healthcare and to introduce our excellent speakers today, Sally Pipes and Gloria Sachdev. So I can't do justice to their impressive accomplishments. So please go to the links to their bios that are going to be on our website. But just a bit about them. Sally is the president, CEO, and Thomas W. Smith Fellow in Healthcare Policy at the Pacific Research Institute. Before becoming the president of PRI, she was the assistant director of the Fraser Institute based in Vancouver, Canada, and she's Canadian. Sally is an important author. You'll see her book linked in our healthcare brief. She's a speaker, a columnist, writes a number of op-eds, and her latest book is called False Premise, False Promise, The Disastrous Reality of Medicare for All, which reached #1 on Amazon's healthcare bestseller list And in the book, she describes the issues with Medicare for All, the stepping stone approaches to Medicare for All, single payer systems in Canada and the UK, and importantly, she comes forward with a vision to deliver affordable, accessible, quality care in the United States. Gloria serves as the president and CEO of the Employers Forum of Indiana, and she's a clinical associate professor at Purdue College of Pharmacy and an adjunct assistant professor at Indiana University School of Medicine. The forum is an employer-led, multi-stakeholder healthcare coalition whose aim is to improve the value of healthcare. And as she'll describe for you today, she's focused on across the country on hospital prices, quality, transparency, value-based healthcare benefit and payment strategies, and health policy. So welcome, Gloria and Sally. We are so honored for you to be here and for joining us on this call. So Sally, let me start.
Thank you.
Healthcare in the U.S. has been debated for years, which I personally experienced. Where are we now? And are the public's expectations about healthcare going to shift because of the coronavirus crisis?
Well, thank you, Angela, and it's a delight. And I've known Sylvie for a few years now, so I'm really excited by the policy circle and what you're doing and what you're trying to do. As Angela said, I'm a former Canadian. I grew up under single-payer healthcare, so this has been something that I've been so involved in for so many years. I won't admit how many years it's been. Anyway, today, single-payer healthcare, it's very, very much on the radar screen of everybody, politicians, the media, the public at large. This was not an issue, single payer or Medicare for all, prior to 2016. I mean, we knew about it. I wrote about it a lot, but the public wasn't engaged. But in 2016, when Senator Sanders was running against Hillary Clinton for the nomination, he really pushed Medicare for all, single payer. And so it's been out there. And then he was, of course, running for the Democratic nomination, and he didn't get it. He really pushed single payer. And I want to just say that a lot of people in America don't know what single payer Medicare for all means. What it means is that all private coverage would be outlawed, would be banned, and the government would be the only provider of health care. It's interesting that the Kaiser Family Foundation, the Gallup polls, have just recently shown that 55% of Americans support Medicare for all. The Hill Harris poll came out just this week showing that 69% of registered voters polled are supporting Medicare for all. It's interesting, though, that a lot of people don't really know what Medicare for all means, and I just described it. But when asked, if you were to lose your employer-sponsored insurance, would you still be supporting it at 55%? And unfortunately, or fortunately, that support goes down to 37%. Also, if you ask them about, would you want to pay higher taxes for Medicare for all, support goes down to 37%. And we have, as Gloria probably knows, about 178 million people in this country have employer-sponsored coverage, 71% rated as good or as excellent. So, single payer, it would be very, very expensive. The Mercatus Center and the Urban Institute costed Sanders' plan out at $32 to $40 trillion over 10 years. If you doubled all of the corporate taxes, all of the income taxes, it wouldn't be enough to cover it. And so it would mean, just like in Canada, and I'll talk about this later, long waits, ration care, and new taxes. And under Senator Sanders' plan and other single payer plans, in order to make this work, and it would still mean long waits and ration care, doctors' pay would be reduced by about 40% down to match the Medicare rates. American primary care docs earn about $218,000 a year on average, Canadians $146, and Brits $134. So the cost of this plan would be very high. It would result in the same situations that patients face in the UK and in Canada. And as Amy Finkelstein, an economist that I really respect at MIT, has said, the cost at 30 to 40 trillion over 10 years is probably low, because when people think something is free, they will demand more of it. of course, that is what Senator Sanders is saying. Single payer is free. And of course, we know it's not, it has to be paid for. So those are my sort of introductory comments.
Thank you, Sally. So Gloria, you come with a perspective about really who is paying for a significant portion of healthcare, the employers. And these are businesses across the country that produce different kinds of products and services, yet they're in the business of providing healthcare benefits for their employees, either self-funded or insured. So when we think about the delivery of healthcare and those healthcare benefits that people value so much, there's a lot of discussion about the government, but what about the employer?
Yeah, so thank you so much for allowing me to be here. It's a real privilege. I thought it might be a good idea to just level set everyone. I'm not sure if everyone has a healthcare background, but when we consider who the players are in healthcare, or at least, we have purchasers of healthcare, so who's actually paying for healthcare, and that does include employers, and employers are the largest purchasers of healthcare, followed by Medicare, Medicaid, and then the uninsured. So those are the four buckets as far as purchasers go. Insurers often, so for employers have two options. They can either go negotiate themselves, so they'll negotiate for services with a hospital, a lab, they might have an on-site clinic, or which happens more, and that typically happens if you're a smaller employer, or it could be an option for a smaller employer. Larger employers and most employers contract with an insurer, such as Anthem, United Healthcare, Cigna, Aetna, Humana, and they, as an insurer, they develop networks. And so they contract with providers, they contract with labs and hospitals, physicians, some pharmacies are on the PBM side, but other pharmacist services on the inpatient side, x-ray, and so on. So those are the three buckets. You have purchasers, you kind of have these folks in the middle, if you will, our insurers or third-party administrators, and then you have the providers. And that's how they're typically connected. It's not working well from an employer perspective. And we did a study looking to see how much employers were paying as a percent of Medicare. So oftentimes you'll talk to hospitals and they will say, and the reason I mean, hospitals think I'm picking on them, but I'm not really picking on them. It's just that when I look at the pie of healthcare costs from an employer perspective, they're 40% of the pie. So that's why we're focusing on that. They're the largest piece of the pie. And so hospitals, their prices have gone up, and employers didn't really understand that. They would see their healthcare cost trends go up year after year. For the last 5 years, it has gone up on average 5.5%. So between 4 and 7%. And so that means in a 5-year period, you're looking at 30–40% increase in your healthcare costs. It's on a complete non-sustainable track for employers. And so to Sally's point, and in those surveys that she alluded to earlier, we have a lot of employers that are just fed up with healthcare. They're like, I can't afford healthcare. I'm ready to get out of healthcare. So we are really at a pivotal point. Either we fix healthcare, and make it what we want it to be, which is a functional marketplace, or we don't. So a big, if I could say what are the two biggest problems, the prices have gone up, and we can talk a little bit about why the prices have gone up. And then there's been a lot of consolidation, and that's contributed to that. The health systems have gotten, we've seen them all merged, across the country. They not just horizontally, integrated, they vertically integrated as well. So they just have more control when they're at the bargaining table with the health plans. The health systems have more power, if you will. And also we have no lack of transparency to the purchasers of healthcare. They don't really know what's happening at that table. The contracts that are signed have been, there are gag clauses around those so that no one can share what that negotiated rate is. So certainly we have some opportunities for improvement.
Thank you, Gloria. Yeah, we can talk about a lot of problems that we have in the U.S., the lack of consumerism and transparency and the high cost, but when we compare what that means to what there is in other countries, we have to say, is that a trade we would be willing to make? So Sally, you are the expert on this. You hit on it a little bit earlier, but make some of those comparisons. Is it a trade we would be willing to make? And if so, why? Or if not, why not?
Well, I'll first say that, I moved to the US in 91 to take over PRI. And of course, my mother, of course, was alive and in Vancouver and actually died from colon cancer because as a senior, she couldn't get a colonoscopy. But that's sort of beside the point. She used to say, I hope you're not becoming one of those impatient Americans. And I think I probably am an impatient American now because I am an American. But, Americans are impatient and they would not put up with what Medicare for all would mean for them. So I'm Canadian. I think I'll talk a little bit about Canada and a bit about the UK. Canada is one of 3 countries in the whole entire world that has, and Sylvie knows this, a true single payer system. The other 2 are Cuba and North Korea. Great Britain, the National Health Service, which is almost 72 years old, is a universal coverage program. 90% of Brits have are covered under the national health and about 10% under private coverage, and that is definitely growing. But I talked about long waits, ration care, higher taxes. The average Canadian family today, well, actually last year, 2019, waited 20.9 weeks. That's over 5 months from seeing a primary care doctor to getting treatment by a specialist. And that's up from the number of 9.3 weeks back in 1993. There are 1 million Canadians waiting on a list waiting list, waiting for treatment and to get a doctor. The average wait in Canada today for an MRI is 11 weeks. The average cost of the single payer system, which of course, as I say, Senator Sanders says is free, Canadians pay for their health care, the long waits, the ration care, in hidden taxes. And the average Canadian family last year paid $13,311 in hidden taxes for a healthcare system that makes them wait. There are about 330,000 Canadians out of our small population of about 35 million, fewer than in the state of California, who cross the border to pay out of pocket for procedures that they think the long wait is just too long. So, these are things that the American people have to understand because government would have to set a global budget. As I said before, the demand would be much greater than the supply, and therefore we would have the ration care and the long waits. Remember when Senator Sanders was in Vegas campaigning last fall, he had a heart issue and he needed urgent angioplasty surgery. Well, in Canada, he wouldn't have had it immediately. He would have had to wait between 3 and 11 weeks, even if he had an urgent angioplasty issue. So, we really need to understand what this means. This Canadian crooner, Michael Bublé, who I love his Christmas album, when his 3-year-old son in Vancouver was diagnosed with liver cancer, he didn't wait around for the Cancer Control Agency to determine what kind of treatment he could get, what doctors could he see. He immediately went to Los Angeles to the Children's Hospital of LA, had his cancer treatment. Bublé said the doctors and specialists were fantastic. And now 3 years later, his son is cancer-free at this point. As just retired Madam Chief Justice Beverly McLaughlin of the Canadian Supreme Court said, when she was making a decision on a Quebec opening up of healthcare in a Quebec case with Dr. Chouli, she said, access to a waiting list is not access to healthcare. In Great Britain, there are 4.4 million Brits on a waiting list for treatment as of late last year. The National Health Service has a 62-day target for getting cancer treatment. That target has not been met for over 5 years. And the UK is at the bottom of international comparisons in industrialized countries for cancer survival rates 5 years out. As Nigel Lawson, Thatcher's former Chancellor of the Exchequer, said, the National Health Service is the nearest thing to a religion that we have, and therefore people feel they can't criticize it. One of the people at the Guardian newspaper said, the NHS is the world's best healthcare system. Its only black mark is its poor record of keeping people alive. And of course, we all know Mick Jagger, frontman of the Rolling Stones, said, his brother said when he had to have a heart valve replacement, thank goodness Mick didn't have to wait in line for the National Health Service. So I think these are the kinds of things the American people need to realize about government takeover of healthcare. And I am an impatient American. I don't know where I'm going to move if that becomes a reality in America. Thank you.
So Sally, that was good. Getting Mick Jagger in a Zoom
Yeah,
call was a talent. So
right.
Gloria, you touched on a little bit healthcare costs in hospitals, but talk more. You've been doing a very important study of hospital costs across the country, not just here in Indiana. And the question is, so what have you found and what should we do about it?
So we didn't really intend to do this. What happened, we just kind of stumbled upon this study, and I'm not a researcher by background and training. I'm actually a pharmacist by background and training. So, but being a pharmacist, I'm very evidence-based. And, you know, if people say something to me, I need to see the data. So when I first took this job at the Employers Forum of Indiana about 5 years ago, the employers were coming up to me and saying, you know, how come the costs in Indiana are higher than they are in other markets that I have? And so these are large employers that have a footprint in multiple states all over the country. And I would say, well, are they higher in Indiana? And I wonder, how high are they? So we did a literature search, and we really didn't find hardly anything to compare prices. There was a couple of old studies. They were done by Chapin White. He's a policy researcher that has his PhD from Harvard, and we kind of cold called him one day and said, look, we have this idea. It took us like a year of reading to figure out an idea. This idea was, could we compare prices? Because Medicare prices are publicly available. So you can look up what Medicare pays for anything. And then we knew what employers were paying. And so could we do just a ratio? You know, what are employers paying as a percent of Medicare in Indiana? So we did that first study and published it in 2017. And our employers were floored. I mean, speechless. We were paying 272% of Medicare. So they were like, we're not paying 10% more than Medicare or 50% more than Medicare. We're paying 272% of Medicare. I went to the hospital CEOs and I said, you know, this seems kind of high. What do you think? Because they're members of the forum as well. And they're like, oh, everybody cost shifts to employers. Everyone knows that. We can't make it on Medicare and Medicaid alone. So the idea became, well, can we benchmark this? How high are we? And we decided, I went around the country and invited a lot of folks to, I was hoping to get 6 or 7 states. We ended up getting 24 more states in a 6-month period. There's a huge demand from purchasers. Everyone wants to know what the prices are before you pay for them. I mean, that's how you pay for everything else. You don't get a bill. I mean, if you can, I mean, can you imagine going to Starbucks and then getting a bill like a month later? You know, that this is how much you owe. That's ridiculous. And then if it came back really high at like $50, you're like, what did I order? Why is it $50? You know, so that's how healthcare works right now. And so of the 25 states that were studied, and this study came out in May of 2019, we contracted with Rand Corporation to do the analysis, and it was funded by the Robert Wood Johnson Foundation. So 2 really prestigious organizations. We found that Indiana had the highest hospital prices among the 25 states, and we were paying 311% of Medicare, where Michigan, our neighbor, was paying 156% of Medicare. So they were paying half of what we were paying for the exact same type of patients, same type of services. So we controlled for all of that, so prices were comparable. We are doing another study that will be out in September, and we hope to have all 50 states. And this information is the first study of its kind. It actually allows employers at the hospital level. So we published it by hospital name. So you could look in your community and say, okay, IU Health, St. Vincent's, Franciscan, you know, all the hospitals would be lined up and see what they are being paid for inpatient services, outpatient services, and total as a percent of Medicare. We also did include some quality metrics, but I would be the first one to say we need to do a better job looking at quality, because now what has resulted, to answer your the second half of your question, I mean, initially employers had to kind of digest the information. We met with the presidents of Anthem, United Healthcare, trying to understand how did they negotiate these really high rates? Like, how did that happen? Is this the best you could really do? and understanding what the dynamics were around that negotiating table. And I alluded to some of those earlier. So now what employers are doing is they want best quality at best cost, like we all do, right? And we can shop for healthcare in a rational way. But the only way we're going to all be, in each of us and each organization, is if we have price transparency and quality transparency. It's like shopping for a fridge, or a car, or I don't know, anything that we shop for. You know what the price is, and you can kind of research it a little bit. And then you decide, I want a Ferrari, I need a minivan, and you look what the costs are and you pick it. And we need that for healthcare. So these studies help us with price. We don't get all the way down into every procedure, but those studies are coming, and we are partnering with other folks in that. And then we're looking at a lot of different ways to slice quality, but we want it just to be publicly and freely available. This is not something that should cost money to employers. Like, we're spending hundreds of thousands of dollars on these studies, but that has to go away. We just need to make it available to everyone so they can make choices.
Gloria, thank you for that. So we are doing this Zoom call in the middle of a crisis, a healthcare crisis. We're hearing stories about how hospitals are, we're managing access to hospitals in terms of coronavirus, and we're not having elective procedures, and so their revenue is down. There are some healthcare workers who are working really hard, and some who can't work at all because of this crisis we're in, which leads to a bunch of different possibilities. One is more regulation, and one is deregulation. Sally, I know you're hopeful about the potential that there might be deregulation. If so, how would that work, and what might that be?
Right. So during the coronavirus pandemic, there's been a lot of deregulation things that have been going on. And as you say, I'm hoping that after if and when the pandemic ends, that these things will become permanent. One of the top ones is telehealth. And that is where a patient doesn't need to go to his doctor's office, sit in line, and that where things can be done immediately, they can be done over the phone, over the computer. You can also, through telehealth, get access to some of the very best oncologists, people who are specialists, because your doctor will have contacts with these oncologists, and you can sort of set up a path to what is the best treatment for you. And you wouldn't have to go to Sloan Kettering or to, Mass General or whatever. So telehealth is really being used. And actually, the Cleveland Clinic has opened it up a lot, NYU Langone. And I'm reading a lot from patients who say, this is really terrific. I don't drive, I don't have a car, it was always a problem. So telehealth is something that I've been talking about for far too many years, but I'm certainly hoping that it will continue after. And even Medicare patients now, under Trump's appropriations bill, are allowed to use telehealth. A couple of other things: expanding scope of practice so that nurse practitioners and physicians assistants can do some of the things that doctors are doing, but now a lot of states are opening up on that. Licensure is another thing, where if you're a doc approved to, you've passed the boards in Washington State, but you can't come to California and practice. I think that in America, if you go to a American university, you graduate in medicine, you pass the boards, you should be able to practice medicine in whatever state you want. If there's a shortage of docs like now in New York City, you should be able to go to New York City and practice and help out there. Getting rid of hospital certificate of need laws. I don't know whether Gloria is interested in that, but they do keep new competitors out of the market.
Yeah. Cannot stand CON. I'm with you all the way on everything you've said so far.
And the last thing I would say is, medical school. Medical school, as we know in America, is very, very expensive. I think in many cases for primary care, the number of years to do, after you do 4 years of undergrad, then maybe do 3 years. Duke, Ohio State, UNC Chapel Hill are experimenting with 3-year medical programs, and I don't see that that's a problem. Then you go on if you want to become a specialist, but I think you can reduce that, get docs out in the field. We're already seeing from the American Association of Medical Colleges, by 2032, there will be a shortage of 122,000 docs in this country. And that's not even counting at the fact if we went to Medicare for all, where the reduction would be even greater. So those are some of the things that I really love, and I hope will become permanent when we get over this pandemic.
So Gloria, I see you agreeing with some of that, but I know that you have a few regulatory approaches that might be additional regulation that would be appropriate. Talk about those.
Yeah, I agree with every single thing Sally said.
Oh, well, that's very rare that people agree with me, so I'm very excited. Thank you, Gloria.
Yeah, no, I mean, all of it, scope of practice, licensure, non-competes, all of that's got to go. So we have some other issues also, and while you're deregulating on one side, what has happened is you kind of got these monster health systems, and they've been able to impact the contract so much. So as I mentioned, the reason there's no price transparency, and the reason you can't shop for healthcare if you want to get your eyes lasered, or you want to get a colonoscopy or a mammogram, and you want to shop around and you want to ask people what the prices are for that type of service. That doesn't exist right now. And the reason it doesn't exist is because the health systems and sometimes the health plans, those insurance companies, they sign these contracts with each other because they build a network, as we mentioned earlier, and they have gag clauses, which says neither party is allowed to disclose what the negotiated price is. That's not helpful because they, the employer hired the insurance company to do a job, and then they can't even tell them all of this level of detail because they signed a gag clause, a contract with a gag clause. So one thing in Indiana this past legislative session is we worked really hard to prohibit gag clauses from being in those types of contracts. So that was probably one of the bigger things we did. We're really focused on transparency. People in the community need to be able to see prices, and that's something else we really focused on, and providers are going to have to post their prices on their websites. There was some federal legislation along that as well that's being contested by the American Hospital Association and AHIP. So anti-competitive language, again, if you are a big, large health system and you don't want the insurance company or employers to send patients other places, you want them all to come to you, you can, because you're so big and everyone wants them in your network, and an Anthem or United can't live without some of these large health systems in their network because it would just the employers wouldn't want it. And so they have anti-competitive language. Again, we have to remove a lot of these barriers. It's kind of deregulation by legislation, if you will. So we can't have most favored nation, all or none, anti-tiering, anti-steering, all these clauses, if you will, that are in these contracts. All of our largest health plans have these contracts in place. So that will be a big focus for us next year. And we look forward to the challenge. I mean, the challenge is huge. The hospitals are now in this new environment, the heroes, if you will, of our society. And we have to somehow figure, and they are, I mean, my husband's a physician. I consider myself a provider. I worked in primary care for 12 years. I am really on the front line of understanding what's happening. And the providers and the physicians, nurses, pharmacists, social workers, I'm not talking about them. I'm talking about the hospital administrators. The heroes are the providers, the actual practitioners, okay, not the hospitals. They are doing a good job. We thank them for doing a good job. We're lucky we have high quality and easy access, as Sally mentioned. That doesn't mean that we have to pay 300%, 400%, 500% to Medicare. I mean, some of the hospitals are getting paid in our country over 1,000% to Medicare, and their quality is no better. So we've done a lot of studies to say, are the high-priced hospitals higher quality? And the answer is no. Sometimes they're the lowest. So we just need more transparency as just a foundational measure if we want to have a functional marketplace. And that is something that we'll be working on.
Okay, Gloria and Sally. I'm going to turn it over to Sylvie, and she is going to facilitate. We have a number of members and participants on the call who are chatting and who would like to ask you all questions. So Sylvie?
Great. Well,
Thanks,
thank
Angela.
you for those remarks. And I'm a fellow Canadian, and so I grew up in the single payer system, so I can totally relate. So we have several questions, some that were submitted before and some that came through here. One question came from Shannon Kanyina, a circle leader in Dallas. Her question is provider autonomy to exercise discretion in patient care and treatment overruled by the COVID policy, and how? I don't know if you can answer that question in some capacity. Concerning the laws that are in place right now, if you could comment on that, who directs how hospital and patient care is prioritized?
I don't know if maybe I can jump in, and Sally, then
Yes.
you can. So, I'll talk about it from a provider, health system perspective. Provider autonomy is not getting patient, that provider-patient relationship still exists. They are managing their patients. Now with COVID, it's very structured, and it has to be, because there are very limited resources still today across the country. PPE, personal protective equipment, is very scarce. People are having to, reuse their same little surgical masks. People are making homemade face shields and masks all over the country. It's still a big problem. So you have to have some sort of understanding and structure around that. Hospitals have said, because we don't have a lot of PPE and we don't want to expose our doctors and nurses and other healthcare practitioners, and I should say even the janitors, just everybody in the hospital that's making it function, to unnecessary risk, because we don't have proper PPE and we don't have enough testing. We can't expose them, so they've had to cancel elective procedures. Had they had a whole bunch of testing and had they had adequate PPE, the doctors wouldn't be in this situation. Now they are starting to open up elective procedures. We are getting more PPE and we are getting more testing in. So there is some regulation. There needs to be some sort of, I know at one hospital down here, they took all of the cancer patients and all the immunosuppressed patients, shifted them to another hospital, and put all the COVID patients into another hospital. They have shifts of doctors, because we expect the doctors and nurses to go down. So you can't just have everybody up front all at the same time. Otherwise, you could be, we learned from New York City, right? What happened there, and in other countries as well. So they have certain doctors up front, and then they sent a bunch of residents home, sent all the medical students home, but they're plan B, plan C, plan D. So it has to be organized somewhat like one of the CEOs said, like a military structure. There has to be some organization to all of the supply, because it is a bit of a war right now.
Yeah. So, we have another question from Stefania Vaughn, a circle leader in California, and I'll turn it to Sally. The issue of the healthcare, and actually even during this COVID pandemic that we're facing, but also broader, and maybe this question goes to Sally, how could this be solved without government involvement, to keep government limited? What do you see the path, the role of government in this and managing this crisis, as well as kind of fixing these issues that you've brought up with healthcare? And this is really at the heart of what the Policy Circle is about, is discussing what is the role of government, of private enterprise, of civil society in addressing these big issues. So maybe Sally, you can address this question.
Of course. I think a lot of people in the US, and certainly people in Canada, think that we don't have any government health care. 50% of the American healthcare today is in the hands of government, whether it's through Medicare, which Gloria has been talking about, Medicaid, the program for low-income Americans, the CHIP program for children, and of course the Veterans Administration, which is a single-payer system and which has not been serving our vets very well. So we have a lot of government in healthcare. I believe that universal choice will lead to universal coverage. We need all kinds of different healthcare plans so that people can get the type of coverage that they want. Health savings accounts are a great way to put consumers and patients and doctors in charge. Short-term limited duration plans, which have been banned in California, are great for young people because they don't have to have the 10 essential health benefits. They're cheaper, it gives people more options. So we need to really open up the system. And it was the federal government that got us into this mess during World War II when wage and price controls were in. They gave employers the ability to write off the cost of their health care. And we as employees, if we have an ESI, we get our health care tax free. But the poor person that's in the individual market goes out, they have to buy their health care with after-tax dollars. So I think with COVID, I know I'm in California. I wanted to get my annual mammogram, and they won't even return your call at Sutter Health. They've got these big groups. They've got a lot going on. But I would say that a friend of mine who is head of obstetrics and gynecology at a major New York hospital, she said that so many people have been made nervous about coming in because of COVID that they're having home deliveries. These are patients who have high-risk pregnancies about to happen, and they're going to local hospitals. So there's a whole lot going on with COVID that is really sort of tightened up the market, and we need to have access to some elective and non-elective surgeries, particularly for people with cancers.
Yeah, thank you. We have another question here from Hadley Manning, who's a Circle member in Denver. Her question is that what are the implications of Trump's administration plan to pay hospitals for the treatment of uninsured COVID patients? And maybe Gloria, having done your study, could maybe help shed some light on this question, if that's something you looked at, and also what are the discussions that you're seeing with your employers forum?
Yeah, so we're still assessing that question, but what is unfortunate about the way the money has been rolled out, the initial $100 million that's supposed to go to the providers and health systems as part of the CARES Act, I believe 60 million of it has been rolled out. It came in a first 30 million bucket. The hospitals didn't want it to be known that how much they were getting at the hospital level. And so it's only being reported at the state level. So it's hard to say. You can look up their finances, and some of the largest health systems are financially doing the best. They are, because they've been able to command these really high prices, and they have in their, this is publicly available through the Medicare cost reports, they'll be netting $1 billion per year, year over year. It's those smaller hospitals, those rural hospitals that are really in jeopardy, but we don't know how much they're getting. The way the government gave out the first 30 billion to hospitals was based on 6% of what they paid them the prior year in fee for service. Again, that is not the way. I don't think that, and I think they quickly realized that after the first installment went out. They didn't treat the second installment that way, or the next installment. They're being more thoughtful about need. Where does it need to go? Which are the hospitals in jeopardy? Where are the COVID patients? Who is short-staffed? Just paying people just because they saw a lot of patients really just pads the largest health systems pockets the most. And that's not the best strategy going forward. Texas got over $2 billion. Florida got over $2 billion, but they have the most. Florida's got a lot of seniors, and Texas is a big state. New York didn't get $2 billion. So you sit there and say, well, New York is where the crisis is at. Why didn't they get some more money? And so, like I said, we're going to be blinded. Again, there's no transparency where we could say, here are all the hospitals. We know in Indiana that $668 million came in the first installment to over 4,000 providers. That's the level of granularity that we got. We didn't get that itemized in any way. A lot of providers were surprised that money just got deposited in their accounts. It was urologists and, people that are like, why am I getting COVID money, right? Because initially it said that it was if you were seeing COVID patients or at risk for seeing COVID patients. And the federal government kind of muddled through it a little bit and said, well, every patient's a potential COVID patient. So that's why we did that. Anyways, it's a mess.
Yeah. Right. Well, this is where actually, everyone's voice really matters, to ask our representative in Congress. Those are kind of the questions to ask to our representative in the House, actually, since they're responsible for the appropriations. What's the oversight on the distribution? And that would be something we'd encourage, all of our members to write to their representative, to engage in this kind of dialogue. I have another question. We have a lot of different questions from here from our panelists, but maybe perhaps in closing, what would be your advice in terms of at the state level? A lot of our circles are in the states. What would be your advice, and like Sally, maybe to talk first, to engage, to get our policy circle members to engage with their state lawmakers around healthcare and around what would make our representative in state office feel like people and employers are taking the right step to be safe and be back to work? And what would be the type of information that you think would be constructive to share with state representatives to either reform healthcare, make it better, or also to really ensure a prompt return to some level of normalcy? So Sally and Gloria, if you have some thoughts there in closing.
Well, I definitely support giving power back to the states, letting the states decide how they're going to spend the funds that they raise. In California, of course, Governor Newsom is a big fan of single payer Medicare for all, and he has a commission of people looking into the Canadian system, and he's got a lot of pressure. He didn't ask me to join the commission. He did include a professor who I debated and defeated, but he is on the commission and I'm not. But I think states should have power over how the dollars are going to be spent, because each state is different. And I don't know whether I'll end up staying in California forever because it's so depressing, and particularly we may be the first people to get single payer. So we need to, as PJ O'Rourke says, if you think healthcare is expensive now, just wait until it's free. We need to open up the system, price transparency, making some changes to Medicare and Medicaid, increasing the age of eligibility for Medicare. Of course, Joe Biden wants to reduce it, which was his stepping stone approach, I believe, to single payer, because he wants to build on Obamacare, public option, a government option, which I think will crowd out eventually private insurers. So those are some of the things that I support. A lot of them are in my book, of course. So thanks,
Right.
Sylvie.
Well, thank you, Sally, and thank you for joining this call. Gloria, are there, I think, like transparency and asking our representative to ask for transparency at the state level would be kind of a really great message. Do you have other comments that perhaps what would be the best strategy for employers to demonstrate that they are creating a work environment, a service environment that is safe to mitigate the transmission, and also help with the transparency?
That's a great question. I mean, transparency and quality, those are huge overarching. You just go to the RAND studies, they're freely and publicly available. And we put that out on the employerptp.org website. It's just price transparency projects. Everyone can have access to it and see what hospitals look like. But I think for us to go back, we really need to talk to our legislators about, we need testing. There are no recommendations about how to really go back to work. If you go to the CDC guideline, they're limited, and we've reviewed them. All of my employers, all of them, whether they're big ones, or even the small ones, everyone's concerned about how to safely go back to work. The only way we're really people are going to feel comfortable going back to work is in a phased in way. But we have to have testing. So that's the SARS, coronavirus testing, but you need antibody testing. So I believe I had coronavirus. I get exposed when I was sick, had a fever, and had a bunch of stuff going on. But luckily, I didn't have the severe symptoms. But I don't know. I don't know if I had it or not, right? I would like to know so I could go out into the public and work. So we need that antibody testing, and then we need PPE.
So I think, thank you both for joining. I think the comments, as I was seeing, people are learning a lot about healthcare in general, new ways to think about it. And I'd love to have the two perspective on the overall system and then the employer's perspective. I invite everyone to actually look at our healthcare, the Policy Circle Healthcare Brief, and perhaps use that as the topic of your next virtual Policy Circle conversation station. You'll find information there also about Sally's books and also the study that Gloria was referring. You're seeing on your screen now a survey. We'd love for you to answer those questions because it helps us design these calls in a more effective way. And as I said, you know, we invite you to visit the Policy Circle. We have some virtual resources. We have some templates if you want to write to your representative. We have a template letter that you could use to share your issues. Also, you know, if you have some stories that you want to share with us, we invite you to write to communications@thepolicycircle.org. And I'd like to remind everyone, we are a grassroots 501c3 organization, and we really depend on everyone's support to offer this kinds of programming. So so thank you again for joining. So, and please you know, visit our website, thepolicycircle.org, and organize your next meeting online using Zoom or your other favorite online platforms. So thank you guys again for joining us today. Thank you.
Thank you.
Ooh.